Picture this. A woman is 69 years old, retired nurse, sharp, independent, still cooking Sunday dinners for the whole family. Her daughter convinces her to go in for a full workup, which she has been putting off. The doctor runs through everything, nods, and says she looks great for her age, then adds 5 words that start a chain reaction nobody saw coming. Let's just be thorough. 4 months later, that same woman is managing a complication from a procedure she never needed for a condition that would never have touched her. The Sunday dinners stopped. The independence she had walked into that office with did not walk out with her. That story has a name in the medical literature. And today, we are going to talk about it honestly. My name is Dr. Thomas. I am a physician specializing in cardiovascular health and aging. What I focus on specifically is how the body's systems change after 60, and what that means for our approach to medical decisions. In my work with adults over 65, the pattern I keep seeing is this. People who felt completely fine going into a routine appointment and came out the other side managing something they did not have before the test began. That pattern has a mechanism. It has a name. And once you understand it, you will never sit in a doctor's office the same way again. Here is the number that should make you pause. Studies estimate that between 15 and 25% of all medical procedures performed in the United States every year are unnecessary. But the part that almost nobody talks about is this. That percentage climbs sharply after age 65. Not because older patients are sicker, because the risk-to-benefit math changes completely after 65. And that math isn't done out loud in most 15-minute appointments. There is something called the cascade effect. One routine test finds a small abnormality. That abnormality triggers a follow-up scan. The scan recommends a biopsy. The biopsy leads to a procedure. The procedure causes a complication. And a person who walked in feeling fine is now managing a medical situation they did not have before they said yes to a single test. The cascade does not start with the surgery. It starts with the first question. Do you want us to run a few tests? Today, I am going to walk you through 5 specific medical checkups that I would personally reconsider after 65. Not because medicine is broken, because after 65, the risk-to-benefit math changes. And very few physicians are doing that math with you out loud. I will show you why it changes, what I have seen happen to real patients, and I will give you a specific set of questions at the end of this video that will permanently change how you show up at your next appointment. Stay with me through all 5. Number 3 is the one that surprises people most because it involves a test that sounds like nothing but responsible medicine. And number 1 is the checkup. Almost nobody is questioning, even though the data behind it is more complicated than almost anything else on this list. Before we get into it, drop your city or state in the comments right now. I read every single one, and I genuinely want to know who is watching this. But first, one concept, because without it, nothing else I say today will fully land. I call it the longevity lens. When you are 50, routine screening is one of the smartest investments you can make in your health. You find a problem early, you treat it, and you potentially buy yourself 30 more good years. The math is clean. After 65, 3 things change that math fundamentally. First, many conditions that routine screening finds in adults over 65 will never actually cause harm. They grow slowly. They produce no symptoms. In a fair number of cases, you will outlive them entirely. But once a result appears on a report, medicine does not have a leave it alone button. It has a treatment button, and that button gets pressed. Second, your body's tolerance for intervention is not what it was at 50. A procedure a 57-year-old bounces back from in 10 days can mean months of recovery for a 74-year-old, with complications and a quality of life that looks very different on the other side. Third, the cascade. One test, one abnormality, one chain of events launched from a starting point of feeling fine. Keep the longevity lens with you through every item on this list. Let's get into it. Checkup number 5. Routine prostate screening in asymptomatic men over 70. I want to be precise here because this one is easy to misread. I am not saying prostate cancer is not real. I am saying that for men over 70 with no symptoms, no family history, and no prior concerns, The data on routine PSA testing tells a story most men have never been told in a doctor's office. Here is the core issue. A PSA test can detect a prostate cancer that is, biologically speaking, barely moving. A slow-growing tumor that left alone would never spread, never cause a single symptom, and in a 72-year-old man would almost certainly never shorten his life. He would live with it, not from it. But the moment that result comes back elevated, medicine does not wait. Biopsies are ordered, specialists are referred, treatment options are presented. And for a man who is otherwise healthy, treatment for low-grade prostate cancer can mean radiation, hormone therapy, or surgery, each carrying real risks to continence, energy levels, and overall quality of life. The American Cancer Society updated its guidance specifically because of this problem. For men at average risk without symptoms, the risks of finding and treating a slow-moving cancer frequently outweigh the benefits. Philip is 73, a retired postal carrier from Baton Rouge, active, no family history of prostate cancer, no urinary symptoms whatsoever. His PSA came back slightly elevated at his annual physical. Biopsy confirmed a low-grade, slow-growing prostate cancer. His urologist recommended radiation. Philip trusted the recommendation. Within 9 months, he was managing chronic fatigue that grounded his mornings and urinary urgency that changed how he moved through his days. When he sat down with me, the words he used were, "I felt better before they found it than I do now that they fixed it." That sentence is not rare. It appears in the literature with a consistency that should give every man over 70 pause before agreeing to a routine PSA. What to ask instead? If we found something, what would we actually do about it? And is that treatment genuinely better for my life than watching it carefully? Checkup number 4. Routine bone density scanning followed by automatic long-term medication. Before anyone closes this video, osteoporosis is real, and falls are genuinely dangerous in older adults. What I am questioning here is not the scan. It is the automatic pipeline that frequently follows it. A DEXA scan detects bone density. If the result shows low density, many physicians move immediately to a class of medications called bisphosphonates. You have probably heard those brand names in advertisements. The message is, low bone density equals medication, and medication equals protection. Here is what that message leaves out. Long-term bisphosphonate use, particularly beyond 5 years, has been associated with a rare but serious condition called atypical femoral fractures, stress fractures in the thigh bone, the bone you are trying to protect. There is also a condition called osteonecrosis of the jaw, bone deterioration that is painful, slow to heal, and triggered by the very medication meant to strengthen your skeleton. Meanwhile, and this is the part that belongs in every conversation about bone health, the single most effective intervention for reducing fractures in adults over 65 is not a medication. It is fall prevention, balance training. Studies on Tai Chi specifically show it reduces fall risk by nearly 50%, removing trip hazards, installing grab bars, and reviewing medications for dizziness as a side effect. These interventions reduce your actual fracture risk with 0 side effects. Before accepting automatic medication from a bone density result, ask your doctor this. What is my actual fracture risk based on my full profile, not just the scan number? And how does medication compare to a structured fall prevention program for someone my age? That question alone often changes the entire conversation. Checkup number 3. Routine cardiac stress testing without symptoms. This is the one that surprises people, because it sounds so responsible. Your doctor says you are 67, let's just make sure the heart is doing okay. You get on a treadmill, they monitor what happens. What could be wrong with that? Here is the problem almost no one raises in the appointment room. Cardiac stress tests in people without symptoms, no chest pain, no shortness of breath, no exertion-triggered dizziness, have false positive rates that can reach 40% in certain populations. That means in nearly half the cases, the test flags an abnormality when your heart is actually fine. But medicine cannot shrug off an abnormal result. That false alarm sends you to the next phase. In a cardiac catheterization, a tube is threaded through your blood vessels directly into your heart. Risks include bleeding, vessel damage, arrhythmia, and, in rare cases, the catheterization itself can trigger the very cardiac event you were screened to prevent. And if the catheterization finds a partial blockage, which is extremely common in adults over 6, 5, including many who will live decades more without a single cardiac event, you may receive a stent. Here is what I want you to really hear. Multiple major clinical trials, including one of the largest of its kind, found that stenting in patients with stable coronary artery disease did not reduce heart attacks or extend life compared to medication and lifestyle management alone. The stent did not outperform a 30-minute walk and the right medication, but it carried all the procedural risk. The cascade looks like this: feeling fine, routine stress test, false positive, catheterization, stent, blood thinners, ongoing monitoring, no statistical improvement in outcome, and it started because someone said, "Let's just check." If you are finding this valuable, type the number 3 in the comments right now. It is a simple way to let me know you are following along. If you have no chest pain, no unexplained shortness of breath, and no dizziness during activity, the conversation with your doctor should not be about stress testing. It should be about optimizing your actual risk factors: blood pressure, cholesterol, blood sugar, activity, sleep. That is where the real cardiac gains live after 65. Checkup number 2. Routine carotid artery ultrasound in asymptomatic patients. Almost nobody is talking about this one. And based on what the data shows, that silence is one of the most consequential oversights in routine senior care today. A carotid artery ultrasound looks at the large blood vessels in your neck that carry blood to your brain. The idea sounds logical. Find a blockage before it causes a stroke, surgically clear it, problem solved. The reality is far more complicated. The surgical procedure used to treat a carotid blockage carries a 2 to 3% risk of causing a stroke during or immediately after the surgery. In older adults with additional health conditions, that number is higher. The United States Preventive Services Task Force explicitly recommends against routine carotid artery screening in adults with no symptoms. Their analysis is direct. In asymptomatic people, the risk of surgical intervention outweighs the likely benefit. Here is why. A large portion of adults over 65 have some degree of narrowing in their carotid arteries. That narrowing has often been stable for years. Silent, not causing problems. When you screen for it routinely, you find it, and then a well-meaning surgeon recommends fixing it. But the surgery to clear a blockage that was never causing symptoms can dislodge a small piece of plaque that travels directly to the brain. The intervention causes the exact outcome it was meant to prevent. If you have no neurological symptoms, no sudden vision changes, no facial drooping, no arm weakness, no brief episodes of confusion or slurred speech, routine carotid screening is generally not where your energy should go. Your energy should go to managing the real modifiable stroke drivers: blood pressure, blood sugar, atrial fibrillation, if that applies to you, consistent physical activity. If you do experience any of those symptoms, even briefly, even if they resolved on their own, that changes everything completely. That is not routine screening anymore. That is your body sending a signal that deserves an urgent response. Checkup number 1. Routine colonoscopy after age 75 in low-risk asymptomatic adults. This is the one most people have never heard challenged. Because colonoscopies have been so thoroughly endorsed for so long that questioning them, even in the right context, feels almost counterintuitive. But the data for adults over 75 with no symptoms, clean prior scopes, and no family history tells a different story than most people have been given. The United States Preventive Services Task Force explicitly recommends against routine colonoscopy screening for average-risk adults over 75. Their reasoning is not vague. The risks begin to outweigh the rewards. Bowel perforation, a literal tear in the colon, occurs in approximately 1 in every 500 colonoscopies. In a younger adult, that is a manageable complication. In a 77-year-old, it can mean emergency surgery, extended hospitalization, and a recovery that permanently changes independence and quality of life. And that is before counting the preparation itself. The bowel prep in older adults can cause dangerous dehydration, electrolyte imbalances, and cardiac stress. Then there is the sedation risk, which climbs with age. Back to the longevity lens. The colon cancers most likely to be found in asymptomatic adults over 75 tend to grow slowly. Slowly enough that in many cases they would never cause problems within that person's remaining lifetime. Vera is 76, a retired librarian from Charlotte, North Carolina. 2 prior colonoscopies, both completely clean. No family history, no symptoms. Her new primary care doctor said she was due. Vera asked questions and was reassured that it was routine. She went ahead. The prep hit her system hard. By the following morning, she was confused, weak, and dehydrated. Her son took her to the emergency room before she ever reached the procedure. She spent 4 days in the hospital with critically low electrolytes and cardiac strain. She never had the colonoscopy. When she called me after being discharged, what she said was this: "I felt better when I was overdue for that test than I did after trying to take it. What to ask instead? Talk to your doctor about non-invasive stool-based testing. Options like Cologuard can flag genuine warning signs without any procedural risk. And if you do have symptoms, blood in your stool, unexplained changes in bowel habits, or persistent abdominal pain, those symptoms require evaluation regardless of age." Now, the practical piece I promised you. Every time a physician recommends a screening test, especially if you are over 65 and feeling well, I want you to have 5 questions ready. Write them down. Put them in your phone. Bring them to every appointment. Question 1. What is the false positive rate of this test in people my age? This tells you how likely the test is to send you down a path of follow-up procedures even when nothing is wrong. Question 2. If this test finds something, what are the realistic treatment options for someone my age and health status? Do not let the conversation stop at "we found something." Push it to, "and then what?" Question 3. What is the procedural risk of the treatment we would most likely pursue? You deserve to know that before the procedure, not after. Question 4. What happens if we monitor this instead of treating it immediately? For many conditions found in older adults, watchful waiting is a legitimate and often superior option. It is not giving up. It is doing the math correctly. Question 5. What is the most effective, non-invasive approach for this condition? Because, as you have seen today, lifestyle and medication frequently outperform procedural intervention with a fraction of the risk. Any physician who is genuinely in your corner will welcome those questions. They will not make you feel uncomfortable asking them. And if a doctor dismisses them or makes you feel like a problem patient for raising them, that is important information about whether that doctor is the right fit for you. Here is what I want you to do starting today. Before your next appointment, whether it is next week or 3 months from now, write those 5 questions on a note card or put them in the Notes app on your phone right now. Bring that card into the room. You do not have to use all 5. You may only need 1. But having them with you changes how you show up, and how you show up changes what happens to your health. There is someone in your life right now, a spouse, a sibling, or an adult child managing a parent's care who needs to hear what we covered today before their next annual physical. You do not have to explain it to them. You can just send them this video. If this conversation changed how you think about routine care after 65, subscribe to this channel. Next week, I am covering something that connects directly to everything we talked about today. The specific medications routinely prescribed to adults over 65 carry a completely different risk profile at that age than they do at 50, and what to ask your pharmacist before you refill them. If you are on more than 2 daily medications, that video was made for you. Leave a comment below. Have you ever had a routine test lead somewhere you did not expect? Your experience in that comment section might be exactly what someone else needs to read before they walk into their next appointment. Take care of yourselves. I'll see you next week.